So this is my Case Connections video presentation for Unit 2. So the first case I picked was case number 3. A 5-year-old boy is brought into his pediatrician's office for an annual visit. The mother reports he's been a sickly infant and often appears drowsy. She also has concerns over her son's persistent thirst as well as his frequent urination. Blood samples are taken for insulin measurements at time 0 as well as 1 hour after a glucose loading test. So the results of this test are illustrated right here. So what is this information likely to suggest about the underlying biochemical basis for the patient's symptoms? So the patient often appears drowsy, has persistent thirst as well as frequent urination. And when the glucose loading test was performed, the patient's serum insulin levels were 0.8 milliunits per liter as a baseline, and 1 hour after the test, or the glucose loading, they were at 5 milliunits per liter. Compared to the control, the baseline was 6 milliunits per liter, and after the test, 1 hour later, it was at 40 milliunits per liter. So the patient clearly has insulin levels below what is considered normal. All of the symptoms presented in the patient, paired with the results of the glucose loading test, indicate that this patient likely has type 1 diabetes due to an inability of the patient's pancreas to secrete insulin effectively. So what would you predict the patient's fasted blood glucose levels to be given his current condition? So given his current condition, I'm assuming it's untreated diabetes. I would expect his blood glucose levels to be above the normal range. So if it is untreated diabetes, his glucagon levels would be high, which means that blood glucose levels would also be high due to the inability of insulin to contribute to glucose homeostasis. So just due to the little or no insulin response that's happening in his body, I would assume high glucagon levels, which would lead me to believe that there would be a blood glucose content above the normal range. So list 2 regulatory enzymes that are likely to be active in this individual's current condition. So like I said previously, due to the inability of insulin to participate in glucose homeostasis, glucagon levels would be elevated. Glucagon is responsible for initiating glycogenolysis, which is the breaking down of glycogen to glucose, and gluconeogenesis, which is the synthesis of glucose. So, in terms of glycogenolysis, the enzyme glycogen phosphorylase would be active. And then in terms of the gluconeogenesis pathway, a regulatory enzyme that would be active would be glucose 6-phosphatase. So for my next case, I chose case number 4. So a previously healthy 2-month-old female is experiencing jittery spells several hours after breastfeeding. Her mother reports that that since birth, the baby has been fed nothing other than breast milk. Only recently has the baby been sleeping longer than 2 hours between feedings, which is when the mother indicated these symptoms first started. Labs are conducted and the results indicate that the infant has hypoglycemia, which is low blood glucose levels. So epinephrine is administered and there's no increase in blood glucose levels, but there is an increase in blood lactate. The physician performed a physical exam and reveals a liver edge 4 centimeters below the right costal margin, as well as percussion of the right chest and abdomen, which confirms hepatomegaly, an enlarged liver. Blood glucose levels increase after breastfeeding, but they do not maintain glucose levels within the normal range during a fasted state. So, after doing some research about each of the possible diagnoses, I concluded that the infant most likely has a glycogen storage disease. So, glycogen storage disease is a disorder that affects the body's ability to make or use glycogen. Some of the patient's symptoms that align with this diagnosis would be hypoglycemia, fatigue, and a swollen liver. The patient's blood glucose levels were also unchanged after epinephrine was administered. Epinephrine is a hormone responsible for enhancing glycogenolysis, the breaking down of stored glycogen, as well as lipolysis. So when the epinephrine is administered and there's no rise or increase in blood glucose levels, it is safe to assume there's an issue with the patient's ability to break down and use glycogen. The increase in blood lactate levels is also explained by the administration of epinephrine. This is due to the epinephrine enhancing lipolysis. Lipolysis is inhibited by lactic acid, so when the epinephrine is administered and lipolysis occurs, but it becomes unnecessary, so the lactic acid is present to inhibit lipolysis and subsequently shows an increase in lactate in the blood. Another indicator of glycogen storage disease would be that during or shortly after feeding, blood glucose levels are within the normal range. However, when the patient enters the fasted state, blood glucose levels are not maintained in the normal range. To me, this indicates an issue with glucose homeostasis, and in the fasted state, glycogen must be broken down in order to maintain blood glucose levels within normal range. This is why I believe the patient most likely has a glycogen storage disease. So now I'll go into why I believe the patient does not have any of the other diseases, beginning with a hereditary fructose intolerance. So my first argument being that breast milk has a very low concentration of fructose, so while it's possible, it is unlikely that the patient was exposed to a high enough amount of the fructose to have an intolerant response. So there's also more symptoms that go along with a hereditary fructose intolerance, such as poor feeding, vomiting, and convulsions, which are symptoms that the infant just did not experience. And just because of that, I would hesitate to say that the infant has a hereditary fructose intolerance because her symptoms were not this severe. A final point I'd make was that the infant did not improve when she was in a fasted state. With an intolerance, I would expect to see an improvement in the patient when the particular item they're intolerant to is removed or not present in their system any longer. And this didn't happen with the infant. And in actuality, the infant ended up having jittery spells 2 hours post-feeding. So that just leads me to believe that an intolerance likely is not the issue. So I also believe that the patient does not have galactosemia. Galactosemia is a disease where there are mutations that affect the enzymes involved in the breaking down of galactose. Lactose is present in breast milk, and after consumption of lactose, it is broken down to glucose and galactose. The symptoms of galactose that do not align with the patient are feeding difficulties, failure to thrive, jaundice, and lethargy. So similar to the hereditary fructose intolerance, these symptoms just are not experienced by the patient, so I would hesitate to say that this is what's going on. And then similarly to what I said earlier, also about the hereditary fructose intolerance, is that the infant did not improve when in the fasted state, and there was a break from having the galactose. And with, like I said before, with an intolerance, I would expect a patient to improve when the item that they're intolerant to is removed. So finally, the patient does not have a glucose 6-phosphate dehydrogenase. deficiency. This is a deficiency in which can lead to the premature breaking down of red blood cells. Just for starters, it is a very rare disease that predominantly, and if not exclusively, occurs in males. And our patient is a female. In addition to this, while some of the symptoms are consistent with that our patients are consistent with this disease, there's a couple that are missing that are important, such as anemia, jaundice, shortness of breath, and rapid heart rate. So again, with this one, I would hesitate to say that that's what's going on here. Yeah, so thank you for listening, and that's all I have. Bye-bye.